So today I'll make a review for myself on cardiology hypertension. So if anyone else is going to watch it, I'll be grateful. But this is for my own help. If it helps you, that is really good. So in hypertension, we can first say blood pressure of a person. It depends on the race and the build of the person. So different races will and different build of people will have different BP levels. So if someone is really tall or someone is really short, their BP will be different. Not really very big, like not a big difference, but it will be different. And same for different races like Caucasian, African, Asian, and etc. So 45% of the people have hypertension or will develop hypertension in future. So in BP there is a nocturnal dip. The dip is between 4 to 6 a.m. and that dip is always present in all the normal people, and the dip will be around 10% of the baseline value. So if the baseline value is 120, the BP will drop by at least 12 millimeters of mercury. So the in normal people there is nocturnal dip at between 4 to 6 a.m. and the BP of the person will peak at around 12 noon. If the patient has a loss of nocturnal dip on BP readings, it is the earliest finding of hypertension. If the fluctuation is also bigger in patients of hypertension, and systolic blood pressure variation will mean there is increased risk of cardiovascular mortality in the patient. So what is so good if hypertensive patient keeps their hypertension in good control, there is decreased incidence of acute coronary syndrome by 25%, decreased incidence of stroke by 30%, and decreased incidence of heart failure by up to 50%. So optimal blood pressure range is said to be less than 115 by 75 millimeters of mercury. But as I said, the BP depends on race also. So the race dependent value is systolic blood pressure is more than 20 millimeters of mercury, or diastolic blood pressure is less than 10 millimeters of mercury. The cardiovascular mortality changes. So for the race dependent values, I have not noted this here, but if the SBP is more than 20 millimeters of mercury and diastolic is less than 10 millimeters of mercury, compared to the race dependent value, the cardiovascular mortality of the patient will drastically increase. So we have two guidelines. One is by the AHA, American Health Heart Association, and the other is from Harrison's. So AHA divides it into elevated hypertension, stage 1 hypertension, and stage 2 hypertension. So elevated hypertension is when the BP is between 120 to 129 systolic and diastolic is less than 80. Stage 1 hypertension is when the BP systolic BP is 130 to 139 and the diastolic is between 80 to 89. And stage 2 hypertension is when the BP is more than 140 by 90, so 140 systolic, 90 diastolic. But in Harrison, it is not called elevated hypertension, it is called prehypertensive hypertension, which is stated as 120 to 139 systolic and 80 to 89 diastolic. Stage 1 hypertension according to Harrison is 140 to 159 systolic and 90 to 99 diastolic. Stage 2 hypertension according to Harrison is more than 160 by 100. So what we can see is stage 2 hypertension in according to AHA means more than 140 by 90, but by Harrison it means more than 160 by 100. And like I have noted this here, if the if the patient is doing ambulatory blood pressure monitoring, the BP of more than 135 by 85 is hypertension in ambulatory blood pressure monitoring. So there are two types of monitoring, AOBP and the one I just talked about, ABPM. So AOBP is automated office BP monitoring with the machine, and the ABPM is ambulatory BP monitoring. So it will be a BP monitor that will be with the patient at all times, generally in the hospital. So in AOBP we do three readings and we discard the first reading and we take the average of the next two readings. If the reading is more than 135 by 85 millimeters of mercury, then we diagnose the patient as hypertensive. In ABPM, if the average awake BP is more than 135 by 85 millimeters of mercury, we diagnose it as hypertensive. And if the average BP during sleep is more than 120 by 75 millimeters of mercury, we diagnose it as hypertensive too. So now there is also another one, that is HBPM, which is home blood pressure monitoring. So in this we take readings for the 7 days, one and twice a day. So one in morning and one in the evening. And out of the 7 days, we discard the day one values. So actually, the next 6 days average values are averaged, and if the BP the values come more than 135 by 85, we consider the patient is hypertensive. Cuff size when taking BP or measuring BP should be appropriate because it can affect the values. So the cuff size should be 80% of arm circumference in length and 40% of the arm circumference in width. And if the patient has come walking or jogging or was doing something, you should ask the patient to always rest for 5 minutes before taking his BP. And if the patient was smoking or having coffee before coming, you should ask the patient to wait for 30 minutes before taking the blood pressure. And BP in left arm and right arm can slightly differ. BP in leg is taken on the thigh in the middle, and it measures the popliteal artery, the BP from the popliteal artery. So what is white coat hypertension? So white coat hypertension is in clinic there the patient will be hypertensive, but at home when he measures, the patient will have a normal blood pressure. And if the patient has a white coat hypertension, it means that patient is going to develop hypertension in the future, and the treatment for this should be lifestyle modification and annual BP recording with an home blood pressure monitoring system or ambulatory pressure monitoring system. There's another term that is called mask hypertension. So in home the patient will be hypertensive, but when the patient comes to the clinic, he will have a normal blood pressure or maybe elevated blood pressure, which does not pass the threshold for hypertension. So even for this, the treatment will be lifestyle modification, just as white coat hypertension, and we'll also prescribe antihypertensive drugs to this patient. So this was part one of my hypertension. I know I just covered a very little of it, but I am looking forward to making small videos, so it will be better to for myself to pay attention, but also better for anyone else who is going to watch this. So I'll try to keep it below 10 minutes. So that's why I'm going to make many parts, and hopefully I will pay more attention to it, or the other people who do watch it pay more attention. So this was the part one of hypertension, cardiology hypertension, and from the next we'll part cover the causes for hypertension. So I'll end this here and thank you. And if you're watching, I hope you'll stay to watch the next part too. And I'm grateful if you're watching. Thank you.